Before moving on, I have some practice questions. So this question says, it has been determined that a patient is capable of assisting with her own repositioning toward the head of the bed. Which of the following statements made by the nurse will be most effective in instructing the patient on how to best facilitate the move? So our choices. When I count to 3, please push off with your feet. Choice 2, please help by folding your arms across your chest. And choice 3, please bend your knees so your feet are flat on the bed. What do you think? If you chose 3, you are correct. I thought all 3 of these answers sounded pretty good, so if you chose wrongly, don't feel bad. I think I probably did too. So let's talk about why they're wrong. Choice 1. Although it's an appropriate instruction, it fails to provide the patient with instructions regarding how to safely accomplish the action. So please push off with your feet is pretty vague, and what this is saying is that your patient might need a little bit more instruction than that. Choice 2. Fold your arms across your chest. Now, I understand why this one was wrong. This would be appropriate only if the patient were incapable of assisting with the move. So if you have another coworker and you're going to pull them up in the bed, this is what you tell them when you're going to pull them up in the bed. But for someone who's helping, this is not appropriate. So this last one, please bend your knees so your feet are flat on the bed, will most effectively be accomplished if the patient is instructed to assume a supine position. So basically, this is the same as this, but it's with a little bit more instruction on what the patient's supposed to do. Leaves a little less vagueness to it. Here's another question. Which of the following patients would require repositioning? We have number 1, a patient in correct body alignment who was turned 2 hours ago. 2, a patient who's been sitting in a chair for 10 minutes watching television. 3, a patient with paraplegia who's been sitting in a chair for 30 minutes but states that she is comfortable. And a patient who was repositioned for comfort 30 minutes ago after being moved up in bed. Well, several of those seem like they might need to be repositioned, but let's see. Okay, that's what I was thinking. It sounds like there's 2 right answers to me, and there were. So the patient in correct body alignment who was turned 2 hours ago, those of you who have worked in healthcare before know turn Q2 means we turn and reposition patients every 2 hours, so that's why that one's correct. And then the paraplegic patient needs to be turned more often than every 2 hours. So if they're sitting in a chair every 20 to 30 minutes to prevent pressure ulcers, because especially the patient with paraplegia isn't able to feel if their rear end is getting a breakdown on it or not. And sitting in a chair is going to put all of the patient's weight pressure on that one tiny area of their buttocks. Whereas in bed, the weight is distributed over, there's more things coming in contact with the bed, more surface area is the word I was looking for, coming in contact with the bed. Whereas in a chair, very little surface area on the patient's coming in contact. So that's why repositioning somebody in a chair, we do that more often than we do someone in bed, and especially a paraplegic patient who doesn't really have good sensation. Next question. 2 nurses are assisting a patient to move up in bed, and the patient is unable to assist. Which of the following actions is inappropriate? So we're looking for the ones that are inappropriate, and we got to get used to answering those because we're going to see those more on the NCLEX. So remove the pillow, lower the head of the bed to the lowest position that the patient can tolerate, lower the side rails, and keep the bed at a working height. That one sounds pretty good to me. Number 2, place the pillow at the head of the bed, roll the patient from side to side, and place a lift sheet under the patient that extends from the patient's waist to the patient's knees. Uh-oh. I think from waist to knees, we're going to have a whole top half of the patient's going to be dangling off, so I don't think number 2 sounds right. Number 3, with 1 nurse on each side of the patient, grasp the sheet firmly with the hands near the upper arms and hips, and then fan fold the sheet close to the patient. Flex the knees with the patient's body facing the direction of the move. Hands near the upper arms. Oh, grasping the sheet. Okay, so far that one, I'll have to think about that one for a second. And number 4, instruct the patient to rest the arms on the body and lift the head on the count of 3. Lift the patient towards the head of the bed on the count of 3 and repeat the move if necessary. So those all sound good except for this number 2 where they have the draw sheet positioned wrong. Let's see. Yeah. Place the pillow at the head of the bed, roll the patient, blah, blah, blah. And the rationale agrees the lift sheet should extend from the patient's shoulders to thighs. Okay, that one was a little easier than the first one. So now we'll move on. Categories of exercise. Three basic categories we can divide exercise into is isotonic, isometric, and resistive isometric. Isotonic, when we think of exercise, most of the things that I think of fall under the category of isotonic. Isotonic involves movement, so the muscles are going to shorten, lengthen, that kind of thing. So jumping jacks, jogging, all sports are pretty much isotonic exercise. Tonic is motion. Isometric exercises, and actually that term is becoming more common because we have things like Pilates and yoga and stuff like that that utilizes isometric exercises. That's where we tense the muscles without movement, like an abdominal crunch hold that I'm showing here. And then resistive isometric is pushing against a stationary object like push-ups, but it wouldn't be your traditional up, down push-ups, but that I think it's called a plank if you ever do yoga or Pilates, the plank position where you are stationary and you're pushing against the floor but you just hold it. You don't move the joints any until you start to quiver. And I don't like exercise, so I always describe exercises in bad terms. Range of motion was one of those words that I defined at the first. Range of motion versus strengthening exercises. So when you start doing care plans, when you get into clinical, it never fails that a student will deal with the issue of immobility and they have to come up with interventions to help. And range of motion exercises is a great intervention for immobility. But you also have to provide a rationale. And so what students do wrongly is they'll say, oh, well, range of motion is going to strengthen the muscles. No, it doesn't. Range of motion is all about the joints. So when we use range of motion exercises, we're maintaining or improving joint mobility. That's why I have joint highlighted here. Range of motion can only be done on a joint, and so that's how we name it. We would do range of motion on the elbow, or range of motion on the neck, or range of motion on the wrist. Those are all joints, right? So we don't call it range of motion on the bicep or range of motion on the tricep. Those are muscle groups. So we name our range of motion exercises by the joint that it's affecting. Now, strengthening exercises are what we do for muscle groups. It's going to target muscle groups. So we might do bicep strengthening or tricep strengthening. So these are named by the muscle group. And that's where your isometric, isotonic comes into play. Many exercises, especially ambulation, cover both. So ambulating, you're going to strengthen the muscles and also put all of your lower body through range of motion. And so that's why that's one of our favorite exercises to use on patients in the hospital. When a client is unable to move a joint independently, such as someone who's had a stroke and is maybe paralyzed on one side, or if someone maybe has a spinal cord injury and they're paralyzed from waist down or whatever, one of the duties of nursing is to perform passive range of motion on this client, and that's where we put the joints through range of motion for the patient when they can't do it themselves. When we do this, we always need to support the joint by holding the distal and proximal areas adjacent to the joint. So you can see here, this nurse is preparing to put the elbow, again, range of motion is done on a joint, so we call it by the name of the joint. So she's going to put this elbow through range of motion. So she's supporting it up here above and then below. And instead of using above and below, which can be confusing, especially when someone's in bed, we call it the distal and the proximal. So distal and proximal to the elbow joint, she's giving support, and she's going to put this elbow through range of motion exercises. If you'll look at the table in your textbook on page 170, 171, it shows ways to do joint range of motion exercises. And on 170, towards the end, it shows several ways to put elbows through range of motion, the hinge and then the pivot. And then the next page shows how we would do a hand. And those are really good to practice.
If a patient cannot assist with moving up in bed, prepare the bed as shown before and enlist the help of additional staff, or 2 additional staff if the patient weighs more than 200 pounds.
And we're going to need to lower your head of your bed down a little bit so that we can work a little bit more comfortably. Lori, why don't we put the side rails down so that we can... I'm going to have to take your pillow for just a little bit.
By putting the pillow up there, it'll keep you from bumping the patient's head, which I've done before.
Now we're ready to get started.
Take this approach to the move.
First thing I need is for you to cross your
Instruct the patient to rest her arms across her chest.
working, okay? Gonna just put your leg over on top of the other leg, so you're gonna see that for a minute. And now we need to turn you over onto your left side. So I'm going to turn you towards Laurie.
Roll the patient onto one side and then the other, placing a repositioning aid such as a draw sheet under her from her shoulders to her thighs.
Pad up onto your back, so you're going to feel that. And now we can turn you back towards me. And now we're going to do just the opposite. We're going to turn you towards me. Okay? Get ready. Okay, Mrs. Jones, now we're ready to scoot you.
Now face your assistant and firmly grasp the repositioning aid with one hand close to the patient's shoulder and the other hand close to her hip. Your assistant should do the same thing on the opposite side of the bed. You both need to face the direction of the move and flex your knees. Make sure the foot away from the bed faces forward to give a wide base of support. Instruct the patient to breathe out and lift her head on the count of 3.
Okay, one more time.
Then on the count of 3, lift the patient toward the head of the bed using the large muscles in your shoulders, upper arms, thighs, and hips. Keep your back straight and your stomach muscles tightened. Repeat the move if needed, but avoid excess bending or reaching.
Put some pillows under your arm, and then we'll raise your head back up. Okay, so that you're a little comfortable.
Then help the patient shift into a position of comfort.
Okay, that showed you how to position somebody in bed who couldn't help, so that's where you have them fold their arms across. Here's effective transfer
Once the
technique.
patient is sitting upright, apply the transfer belt over his clothing and around his waist.
This is the gate belt that we
Tighten the
talked
belt
about
so it's
earlier.
snug but does not cause discomfort or impair breathing. You should be able to slide your fingers under the belt.
2 fingers in there, okay?
The belt's going to loosen a lot when they stand up, so you can get it a little bit too tight with them sitting.
Slippers on for you, okay?
Then help the patient put on non-skid slippers or shoes, move to the edge of the bed, and place his feet flat on the floor and comfortably apart. Now spread your feet apart. To move your center of gravity closer to the object to be raised, flex your hips and knees. Then block the patient's feet with your feet and brace your knees against his to help stabilize his knees when he stands. Grasp the sides of the transfer belt or its handles if it has them. Unless contraindicated, tell the patient to push both hands down on the mattress and stand on the count of 3. Rock him up to a standing position while straightening your hips and legs and keeping your knees slightly flexed. Maintain the stability of the patient's weak leg with your knee. Once he's standing, pivot him toward the seat of the wheelchair. Have him reach for the arm of the chair. Instruct the patient to use the armrests for support and to ease himself into the wheelchair. Flex your hips and knees to lower him into the wheelchair. After the patient is securely seated, ensure proper alignment and position the wheelchair as desired.
So you notice this patient was able to stand and walk a little bit. We really aren't safe to transfer somebody who can't do what he did. If they're just dead weight and they can't support some of their weight by standing and they can't walk, you need to find another method to transfer them, either get lots of help or even better, use a lift.